webinar. My name is Mike Robling from the Centre for Trials Research. I'm going to be chairing today's webinar, and we know that people are still joining us, so we'll formally kick off in a couple of minutes. I'm really pleased today to be joined from colleagues in Swansea, Sinead, Simon and Dan, and together with them we will be talking about both the HDR-UK, Wales and Treialon Cymru initiative, but particularly this meeting will focus on the use of routine data in trials and some of the work that Swansea are leading on in that space, and also work that we're also doing as part of funded HDR-UK work. The running order in today's meeting will kick off with Sinead Brophy, who leads the consortium in Wales working on HDR-UK, and she'll give you an introduction to the background of HDR-UK and how different components within Wales fit into that. Then I'll be talking about some of the work that we're leading on in Cardiff as part of one component of HDR-UK, which is focusing on developing training resources for researchers working with routine data in trials. Simon Thompson will then be talking about the infrastructure, and Dan Thayer will be talking about how we are approaching making data more repeatable and comparable. So different topics, but all bundled under how we make better use of routine data in trials. The audience today will be, I think, quite diverse, and some of you may know a lot about trials, some of you may know very little about trials, and the purpose of these webinars is really to introduce you to some key topics as both health and social care practitioners who are interested in getting more involved in research, and hopefully we can sort of stimulate some ideas and get you thinking about how we might be using routine data more when designing and implementing trials. We're going to ask each of our presenters to talk for between 10 and 12 minutes, and that will give us some time at the end for questions. So please store up your questions until the end. Put them in the chat if you want as we're going through, and if you have a question for a particular presenter, just make sure that you name them so we can pick that up easily at the end. We are recording this webinar today, and that recording will be made available via Richard Haggerty, who's coordinated the meeting today. So without further ado, I'm going to ask Sinead if she can set the scene for us and tell us a little bit about the history and the purpose of HDR-UK, and over to you, Sinead.
Thanks a lot. So I'll just get my slides show in there. Just let me know when they're up.
Yeah.
That's brilliant. So I'm just going to give a wee overview about HDR-UK, the benefits of linked data in trials, a bit about HDR-UK Wales, and really what we're good at in Wales. So let me just, so HDR-UK has a 20-year vision. It's been funded for the 5 years to start with, and it's now been renewed for the next 5 years. It aims to bring together really all the health data across the UK to enable people to make better use of existing data for the benefits of clinical trials, for patient interaction, but really for discovery and just learning from what we already hold. It has three main areas of activity. So the first one is really the data infrastructure, to be able to hold the data, enable others to access it, link it and use it, and sort of provide the services to that. It runs 6 driver programs, which I can say a wee bit more about in a minute, and that is the areas of research that HDR-UK focuses on. And it runs a sort of one institute partnership model, where it brings together people all working in this space. So like Administrative Data Research UK, for example, NHS Digital, As you can see, many others, Public Health Scotland. So many people working in this space to work really as one institute, working together to enable access for everybody and sort of the benefits from, say, UK Biobank and things like that, trying to bring all this together. So also part of the partnerships is that there are 9 regions in HDR-UK, and we are the HDR-UK Wales region, as you can see there in the green. But we also work with the other regions. So for example, the region in Northern Ireland, in Scotland, North England, you can see there's Oxford, London, and Cambridge. So we try to work across all the regions to work together to bring really the expertise from each region on an all UK basis for grants and just further linking and sharing data. The driver program, so what HDR UK focuses on in terms of the research, are these 6 driver programs, and the people leading them in Wales are in medicines, in acute and chronic care would be Rhiannon Owens and Hamish Lang. In social and environmental determinants of health, that would be Richard Fry, whose background's on geography and GIS and mapping. So trying to bring in data that's more about the geography of where people live. And immunity and inflammation is with Gwyneth Davis, and that's more on asthma and respiratory conditions. But however, we also work on big data, so that's cardiovascular disease and cancer. And as you can see, there's molecules for health, and there's pandemics and outbreaks, which are also themes in HDR UK. In terms of the infrastructure, you're going to hear more from Simon, and he's involved in the technology. So TRE is Trusted Research Environments, which is where data can be held and shared in a way that protects people's anonymity and enables federated analysis. So enables an analysis across the different regions and areas. You're going to hear a bit more from Dan, who will talk a bit about how to have data standards, so being able to make sure that we're all talking about the same thing in how data is coded and how it's held. And also Mike is going to talk about the clinical trials aspect, which is all in the usable data sort of stream. Also streams in HDR UK is working with the public, so PPIE, and also very much on capacity building, so training. And we run an intern program, which at the minute is an intern program for people of African background. So what are the benefits of bringing routine data to trials? Well, on one hand, it can overcome some of the limitations of trials. So where it may be hard to recruit with routine data, you can actually, before running the trial, look at the feasibility in different areas, how many people would meet eligibility criteria, where those people are. Ourselves, we were recruiting people with ankylosing spondylitis. We were able to write to the GP practices saying there is someone with you who would fit this criteria. Please, would you be willing to send them this letter? So it enabled us to recruit much easier for people with a more rare condition. It enables findings from trials to be generalizable to the population, so you can extrapolate up really of people with these characteristics, how many are found, for example, in Wales, and what would the implications be from what you found in the trial if you extrapolated it up to people in the country with those characteristics. Obviously, you can follow up people for a much longer term, so you could do 5-year, 10-year follow-up of people after the trial, using their GP records, hospital records, medications, picking up new diagnoses. And you can cut back on what you need to ask people and have objective data. So instead of asking people, you know, how many times have you seen your GP in the past year, you can actually look at objective diagnosis, medication prescriptions, and pick up how many times they've been to their GP using their GP records. linking to trials also greatly improves routine data. In that people going through trials, you can collect data that you can't get from the routine data. So, for example, people's well-being, their quality of life, things that you actually have to ask people, and this can greatly enhance the routine data. And obviously, trials enable us to randomize, and so you can actually run fully routine data follow-up trials, but have randomized the intervention to start with. So trials now can go forward using apps, using telehealth, using just medical record data collection. And so they can be done in remote areas, in rural areas, or the same trial can be run across many different countries because it's all electronic. And as well as that, what I mentioned before is the ability to flag up people who would be eligible for a trial with GPs or with the doctors who might be might be able to recruit them. So an example of with us, we did Active, which was a trial giving activity vouchers to young people. And we measured their fitness, their blood pressure, their atrial stiffness, and we were able to put that with their routine data and show that deprivation at birth and deprivation level of the school are associated with their fitness and their aerial stiffness. How many hospital admissions they had growing up was related to, it affected their blood pressure. They were more likely to have higher blood pressure. And whether they were breastfed was also associated with their blood pressure as teenagers. So we got a better view of the factors we were looking to change and how they're influenced by other things in the child's past. The HDR-UK Wales leads are myself and Richard Fry. Program manager is Alicia. We have a bid writer now, and so we're set up to help with writing bids for people in Wales wanting to put in new bids. We are set up to bring in new data sets and sources that might be of interest to people and to really co-produce the research with the public and service providers. So we're recruiting a co-production officer. So I'm going to, in the interest of knowing that, so I just wanted to say very quickly what we're good at in Wales. We're good at really deep data, so really having the depth on people. So for example, the census 2011 and 2021 can be linked to data from surveys. So So for example, the National Survey for Wales or surveys with children in primary schools, it can be linked to hospital data, it can be linked to the GP data, so we can really get depth of data with people in Wales. And we also work very much with Administrative Data Research UK, which is with the Welsh Government, and we host a dementia platform, so of really deep data on aging and on the cohorts that recruit people as they age. And we'll be working with the digital medicines portfolio to bring in digitalized prescriptions and dispensing data. So I'm just going to hand over now to Mike, and that's me for the minute.
That's brilliant, Sinead. Thank you very much for that introduction to HDR-UK and the specialisms that exist within Wales in particular. Right, I'm going to just share my slides. Can I just check that people can see that? Okay.
Yes.
That's so picking up on what Sinead introduced you to, I'm going to be talking about a programme of work which is focused on transforming data for use in trials. And this is really overall about trying to develop better support for the use of data in trials. And it's quite focused really on the trials community itself. This is a work stream which is led by Marion Matham in Oxford and Matt Sides in UCL, and there's a leadership team which includes Isla Mackenzie from Scotland and myself in Cardiff. And the overarching aim and focus of this programme of work is really to transform access to healthcare systems data for use in trials, to transform and understand the utility of healthcare systems data for trials. And Sinead talked about some of the advantages of using routinely collected healthcare data. And so this component of the work will be looking at whether and at what point we can start relying confidently on routine healthcare data rather than bespoke data collected prospectively in trials. It will look at transforming our approach to data management and analysis of trial data when it's incorporating using healthcare systems data, and overall to transform our understanding of trials using healthcare systems data. And I really like the example that Sinead provided you about the active study as one example of actually how we can be doing trials differently. Now we have good access to high quality routine data. There are 7 component work packages as part of the work stream, the Transforming Data for Trials work stream. The first of which is about bringing together a forum of key stakeholders who can advise us on the direction of travel for the work stream. So this is a broad coalition of stakeholders. It represents the 4 nations approach that Sinead mentioned, and it builds on existing relationships that we have within the trials arena and also in the broader HDR-UK alliance. And the figure on the left-hand side shows that we're trying to include within this forum both users of data, whether that's researchers or people who are using evidence generated from the analysis of those data at a policy and practice level. It will include data custodians, so those organisations who are responsible for maintaining and making available data to researchers, and also within HDR-UK and the Data Alliance as well, stakeholders there. The purpose across the 5-year programme will be to inform and to identify and address barriers to the use of healthcare systems data in trials, to provide some monitoring and oversight of the outputs of the work, including dissemination, but also I think probably most importantly to set priorities for the programme. So drawing upon that wide range of stakeholders to inform what we prioritise and what we spend more time on and less time on, perhaps. The second and probably the most currently prominent component of the work stream is developing a route map for trialists and a route map for the use of routine data in trials. And so many of you who will already be working in trials may be familiar with the NIHR route map, which takes you from start to finish of the life cycle of a trial, and at each of the stops on that journey, it provides resources and further information which will be helpful for trialists in designing and implementing their study. So what we're trying to do in this work stream is really to generate an equivalent. So it'll be matched to a large extent the existing stops on that NIHR route map, and it will cover again the entire trial life cycle, including what happens at the end of that trial. So what are the requirements, what are the options for making data available beyond the end of a study, and questions about how data can best be archived, for example. Components of the route map will include things that you would probably expect, like how you go about designing and planning trials, how you develop your protocol, through to options for analysis and plans for dissemination, data reuse and archiving, as I just mentioned. And it's the intention that this route map will be developed and made available towards the end of the second year of the running of this work stream, at least in terms of its critical stops. There are 5 other component work packages as part of this work stream. addressing developing courses and training, which is what Cardiff's involved in, undertaking and supporting data utility comparison studies, knowledge transfer and exchange and mentoring schemes. So how can we share expertise and knowledge across the broader network? Like Sinead was saying about the overarching infrastructure within Wales, there's a public involvement and engagement component, and also the accumulation of a case study catalogue to provide insights and confidence to trialists about using routine data in their own studies. Just say a little bit more about our own particular journey in Cardiff on developing training to support the use of routine data in trials. Myself, Fiona Ludwidger and others started a few years ago developing some training funded actually by the Information Commissioner's Office, looking at how we approach the use of routine data in trials, particularly to address some of the objectives of the ICO when reusing routine data. So we developed as part of that the Centric training program, which is a modular online training course, which is still available for those people who would have an interest in looking at that. Subsequent to that, Fiona led on two studies, Comerant and then Primary, the first of which was essentially a Delphi-based study looking to identify and prioritise what might be the remaining challenges when using routine data in trials. So this basically set an agenda for subsequent research, of which the Primary study then picked up two. So we're just coming to the end of the Primary study. I'll say a little bit more about that in a sec. And then now we've commenced with the Transforming Data for Trials workstream led by Marion and Matt. So Primerance was one of the 7 key priorities identified by the Comerant study, and the work has really been driven by Rob Truby, whose image is on the right-hand side of the page there. And the focus of this is about how do we build trust amongst the public when using routine data in trials. And this was some of the feedback that we had in that Delphi exercise. We have developed the training in partnership with the HDR-UK's own training team, which has been an extremely useful exercise for us, being able to draw upon their knowledge and skills. And we've consulted with a wide range of stakeholders, from trials units, members of the public, leads for public and patient involvement and engagement, and also topic experts in a variety of different topic areas. And the result of this is a series of bite-sized videos. These are, say, between 3 and 7 minutes long. These are talking head videos where we have experts and members of the public talking about relevant topics. And these are collated as an integrated training program. Included within this are links to key resources and infographics and further information. Some of the topics that are included in this include what are the key drivers of public trust when it comes to using routine data? How do we go about developing PPI approaches for use in studies that are using routine data? How do we address issues such as inclusivity in that? How do we communicate clearly with trial participants and members of the public about using routine data? And how do we evaluate efforts to incorporate approaches to building public trust in our studies? This training is on the cusp of being available. It's not quite ready yet, but this will be made available on the HDR-UK Futures training platform, and the link to that is shown at the bottom of the slide. And this is accessible and available to all, so you just need to sign up, and then you will gain access to the training materials, which will include Primary, but also a wide range of training materials related to routine data on that platform. The work that we're doing, developing courses for the Transforming Data for Trials workstream, will basically take a modular approach. So we'll be developing a large number of modules of training, which are going to be aligned to those stops on the route map. We're basically going to be concentrating on what we've regarded as our minimum viable product. So the essential components of that route map will be our priority for initial development. Of course, other priorities may come along. So as ideas develop and things become more pertinent for trialists, we can add them into that modular approach. The drivers for the content will include the prioritisation forum stakeholders, as I mentioned, but also trials community insight group, the route map itself, but actually any subject matter experts who have something important to say about the use of routing data in trials. And so subject matter experts, people who are leaders in these topic areas, are essential to the work that we're going to be doing. Just to mention and acknowledge the team in Cardiff who are going to be involved. So myself, Fiona and Rob, I've already mentioned. And then Becky Cannings-John and Vicky Shepherd are two senior researchers within our centre who represent expertise in the statistical analysis of routing data and also approaches to inclusivity and consent in trials, as well as Kerry Hood, who will probably be familiar to most of you and is the director of our centre. And just say thank you for listening, and just a plug, if you are a subject matter expert, and I expect there are a few in this conversation, please do contact us, because we're really keen to reach out and be talking to people who could help us develop some of the training that we think is going to be required. So thank you, and I'll stop sharing. So we move on now then to Simon. So Simon, if you're happy to introduce yourself and talk to us about the infrastructure in Swansea.
Yeah, so I'm Simon Thompson. I'm a professor of health informatics at Swansea University and work as part of HDR-UK and the SAIL data bank and a thing called SERP, which we're about to talk about. We'll just touch on the SAIL data bank in case everyone didn't know. I mean, SAIL data bank is three things really. It's a very robust governance model that has stood the test of time over 15 years now. It's a very large collection of data of health and non-health data covering the full population of Wales and indeed outside of Wales. It's about 32 billion rows of health data that's updated regularly. But it's also the infrastructure which underpins it, which is called SERP. So, you know, this is a slightly out of date slide. This is sort of like mid-COVID slide, but I guess it's just showing the fact that the diversity of use cases in SAIL is quite varied. You know, there's every aspect of health and non-health is covered, but also, you know, down the bottom left, you know, if going back a few years, it was very academically focused, but actually we are beginning to serve the NHS and government more and more and more. In fact, that pie chart has opened up a little bit in the last 2 years anyway. We enable access to data to the right people to do the right research at any given time. So geography isn't the point. We may collect data predominantly about Wales, but actually it's about global reach and a global ability to participate in research across the world. We have a long established ability to do individual linkage in a very swift way, in a very safe way, and we've got a long time collaboration with DHCW. Who are our linkage agents in this sense, and we can link to the Welsh spine, and there's currently developments underway to kind of go beyond Wales and serve a much wider community. So SERP itself is a publicly funded research cloud to support the use of secondary use of data across the many use cases. So it's complicated, and we're not going to go into any depth today. Needless to say that it is all about a bespoke set of infrastructure that's very tailored to the use case of securing access to data for public good in a way that fully conforms to information governance. So we have 27001 accreditation, Cyber Essentials, but we also have UK Stat Digital Economies Act accreditation. So we hold a lot of official accreditations to hold all sorts of data. We hold like police data and health data and all these sort of things. And that's all part of the mix, if you like, for running a secure platform. We have a lot of automation and command and control, and we adhere to the ONS 5 safes model. And I guess it's the fact that actually everything is under a project, and we slice and dice the data, and we give the right data to the right people. But but the variation in people is there as well. So what people need to do their analysis, whether they need a GPU cluster, an HPC cluster, or whether they need certain specialist software, we sort of cater for that to create the research environment on a per project basis to enable the research to go forwards. UK SERP is quite big, or SERP as it's now called. So it is 28 full tenancies. So SAIL is only one of those. ADRC is another one, which is non-health. DPUK has already been mentioned, Dementia Platform UK, and Welsh Government and DHCW has a tenancy, UK LLC. So there's a lot listed there. It's got a little bit more complicated recently because we've now introduced the idea of TREs inside TREs, which is going to make it all very complicated. But for instance, the traumatic brain injury has placed itself inside DPUK, as has Parkinson's, as has Tissue Bank, and the British Heart Foundation Vanguard cohort trials have placed themselves inside of SAIL. So they would have traditionally been a TRE, but they've actually found a home inside an existing TRE to provide many services that allows these research groups to focus on the delivery of the science and not the delivery of running large infrastructure or worrying about information governance. SERP has an international spread. So we have full installs in Monash University and Curtin University in Australia, and we're also running the trusted research environment for the government of British Columbia, Canada, which obviously brings a lot of collaboration opportunities, but also a lot of lessons learned from these partners who are very like the UK in their attitude towards research and the use of data. COVID has obviously come and gone, but I think we were called out as an exemplar way of doing this sort of thing. SAIL completely smashed the delivery of enabling research access to data as part of the pandemic. This really was due to the investment we've made before to be ready. We were just the most ready TRE, I think, and therefore we were able to capitalize on it. But we were able to turn around research projects within 3 days. We were able to provision data within hours, and it really was in a national interest to kind of enable this sort of science at pace. And although the pandemic is obviously a very bad experience for everybody, the legacy of the pandemic is that actually everything's got faster, everything's got bigger, everything has got more ready than it ever has. And I guess there is a legacy of an improvement there as a result of the pandemic. It doesn't stop there. I mean, running a TRE is very complicated. There's lots of things you have to do. So Dan will talk about this later, but we need to provide tools like the concept library to allow the reuse of code and the reuse of shared libraries. We need to support people with data catalogs and data provenance records and the handling of data and all that good stuff. But we also need to demonstrate that the research projects that are happening on the platform are genuinely having an impact in the world, and there's quite a lot of energy goes into tracing the impact of. So what did that science ever do for us, and was it worthwhile science? Linkages, as I alluded to before, with our collaboration with DHCW, we are making linkage much more complicated and much more feature rich in the ability to link English data and international data, as well as just we've obviously been very good at Welsh data for a long time. But we've also do geospatial linkage, and we do like distance from playgrounds and off licenses and so on and so forth. But again, that's evolving to a new level, and we're bringing in geospatial linkage as a very, very first class citizen, if you like, for doing geospatial analysis safely within the context of the healthcare and non-healthcare records. Looking at other tenancies like UK LLC, we've developed abilities to do federated linkage, and the fact that we link all the data in Wales, and then we go to NHS Digital and link all the English data and then combine it together. But also we supplement the cohort data. There's 26 cohorts in this particular TRE. We supplement it with the EHR data from both England and Wales, so that they get a fuller picture of the cohorts. This same technology will be deployed under PRUK, which is an initiative that's out right now, will be brought to DPUK and every tenancy going forward. So we kind of think this is a core infrastructure. It might have been developed in this tenancy, but I think it's something that actually we need to be able to augment existing cohorts and trials with EHR data, obviously subject to the consent of the individuals. Just looking at another tenancy like DPUK, I think they're all fundamentally the same, but the way they operate and the way that they want to report, we have to provide tools to be able to, for each tenancy to be able to see and visualize how it's doing and what its objectives are. But DBUK is leading the charge in some ways because it's doing a lot of image analysis. It's using a lot of HPC cluster. It is doing quite advanced linkage. It is doing tissue banks, experimental medicine. There's quite a few things that it's doing. It has 60 odd cohorts, but it's quite broad in the sense. So picking on one example, DBUK is leading the UK in the standardization of neuroimage formatting into BIDS format, so that actually we get reusable pipelines, and the whole repeatable science is possible. For instance, we're taking the UK Biobank IDP pipeline and make it generalizable across all types of scanners and all types of brain cohorts, to basically to be able to create the derived data sets from imaging data just as a normal byproduct. We have to scale up our infrastructure. HPC and GPU and machine learning is obviously the future, but actually these environments are often not secured, and therefore, although these environments are not so very big compared to, say, big HPC clusters, these are secured all the way to Digital Economies Act accreditation and all the accreditations that needed, so we can put very, very sensitive data into these large compute clusters and do some great things. And through a collaboration with Cardiff University, polygenic risk scores on sensitive genomic data now is an established pipeline, and it's just something that if you put the data in one end, the polygenic scores pop out the other end, and we're contributing that back to all of the cohorts that have contributed genomic data to supplement their knowledge about their cohort. There is lots of innovation happening, though. I mean, Wales has had agreement for 3 years, in all fairness, to flow all the genomic data from the All Wales Genomic Service into both Cardiff University and Swansea University, so to create that secondary use of what effectively is operational data. Everyone's in violent agreement about the architecture, but we just need to actually, go through the process of getting everybody reassured and getting everybody ready for this sort of flow to happen. But an exemplar is the CREST initiative. We could probably use these initiatives in cancer as use cases, if you like, to prove the technical approach is both safe and beneficial to the population of Wales, in order to kind of like de-scope it a little bit, bring it down from all genomic images to the ones that effectively support this trial. And I think that would be very good. SAIL has supported clinical trials for a very long time, but actually we have a proposal out with DHCW who are leading the proposal to how do we support digi-trials in Wales? How can we identify cohorts of people based on the EHR record, basically re-identify them and go through a process of inviting them to participate in a trial? And of course, once they've done that, they're part of the trial, and we could supplement the trial with all of their EHR data, obviously with their fully informed consent. But I also call out, a few years ago before COVID, we did a proof of concept called Retriever. It was about NLP analysis of all discharge and referral letters, and that was proven to be 28 times faster to basically ascertain the appropriate case notes that should be considered for trial selection. That should be really, really effective. And I guess now that the pandemic has gone away, I'm hoping that we kind of dust that off and we go and seek funding to basically turn that into something that is possibly a service for Wales going forwards. Medical imaging is, again, everything takes a while, but we have an agreed pipeline, an agreed infrastructure with Halvar for effectively feeding medical images live from their packs into a TRE for analysis by researchers in a secure way that can be linked to all the other data about that individual. So if you like, a lot of this is about multimodality analysis, and it's kind of, rather than just worrying about the EHR, let's worry about the genomics and the imaging and the wearables and the NLP and all these things. It's getting a very rich environment inside a trusted research environment now. There is a Cambrian explosion of TREs. Everybody's got one now. I think you're going to get one free with your cornflakes soon. But it is about that maturity of a TRE. It's one thing spinning up a few servers, and it's a very different running a service at the scale that we do, and the things you have to do. But the world is changing. Just before COVID, we had a federated compute solution that we were going to roll out to interjoin things, but then COVID hit and distracted everybody. So we are now part of two national level projects on federated analysis, where we send the query out to the data. It consumes the data and answers come back. The initial proof of concept is between the National TRE of Wales, which is SAIL, the National TRE of Scotland, and Birmingham NHS Trust to kind of do this. However, we already have a network of quite a few established TREs, and once this infrastructure is proved to be usable and safe, actually does open up a whole web of possibilities for sort of sending data across everywhere. So as well as that, because the federated analysis has some drawbacks because you never get to see the data. There's another national project to interconnect the national TREs of Scotland and Wales, where we will actually create pipes between the TREs to allow the data to flow between these TREs and be combined for a delayed governance release model, effectively. Again, I think both these approaches are complementary to each other. They are fundamentally quite different, but I think what this is saying is that federated access to data or federated analysis is really on the horizon. Both of these projects must prove themselves and deliver a working product by the end of this calendar year, and both projects are on track to do so. I could carry on talking forever, but I'll stop there.
Simon, that's fantastic. That's hugely impressive body of work, and I think that gives us all a lot to think about in terms of opportunities for trials that are seeking to use routine data. Going to move on then also finally to Dan. Again, Dan, if you'd like to just introduce yourself and tell us about what you're going to be presenting on.
Hi, thanks. I'm Dan Thayer, and I'm a lead for the analytical services team in the SAIL data bank, and I wanted to talk a little bit about what we're doing with the phenotype library and the relevance to clinical trials. So I wanted to start off by saying that one of the real challenges of using routinely collected health data for research is kind of how do you go from what's in the data to the concepts you're interested in measuring, like the health events or health states that you're interested in measuring. Oftentimes it's not straightforward to figure out who has received a treatment or who has been diagnosed with a disease due to issues like the kind of quirks of data recording and data coverage, various kind of quality issues. And so kind of researchers working with these sorts of data sets have developed all sorts of methods of, how do you measure things out of these data sets? Sometimes it's as simple as kind of clinical code lists, but it may be more complex, like an algorithm with some rules that was developed based on input from clinicians. Or then there are more advanced approaches like machine learning or natural language processing as well that may be used to kind of define what you're measuring out of the data. And increasingly, this has been recognized as kind of a discipline in its own right that's often being referred to as electronic phenotyping, and that these definitions that are created of how concepts are measured in data are kind of important products of the research, as well as important things to describe clearly when publishing research. Alongside that, also, there's the whole movement towards reproducible research and how important it is to be able to fully and clearly document what you have done and be able to share that and enable others to kind of reuse it or reproduce your work or build it on it and do something else. And one widely accepted articulation of this is the FAIR principles, that kind of any methods in your research should be findable, accessible, interoperable, and reusable in order to kind of both ensure the quality of research and get the most benefit out of what you've done and enable others to build on it. And so kind of at the intersection of these 2 points is the HDR-UK phenotype library, which is a tool that supports kind of the reproducibility of these definitions of how things are measured in the data. And it was built on a project Sales started a few years ago called the Concept Library, and it's now been adopted by HDR-UK as a UK-wide resource, but it's intended to be the place where you can create these definitions, document what you've done with metadata that describes kind of their meaning or how they've been validated, as well as use them and share and publish them. And I'll quickly go to the library itself now. This is the resource that we have. It has over 1,000 different phenotypes in it. And you can kind of search and find things that you're looking for. Here I'm looking for asthma, and there's a number of definitions related to asthma here. Look at one of them and see, here's a bunch of information about, what this definition is, what data sources it applies to, some information about how it was created, publications it's associated with, and so on. We also have a complete, if it's based on clinical codes, then we have a clinical code list, and we also have a complete version history to, kind of have the full history of what you've done. And if you want to publish a paper using this definition, you can refer to this and cite it. You can cite a particular version, and then if this is later updated in the future and improved, your paper will still cite the exact version that you use, and it won't change. And also, all of this is accessible via an API, which enables you to actually use it and integrate it into an analysis workflow. Here's an example that's actually, I'm running live now. In R, I'm using an R package we've developed that accesses that API. I'm actually getting a phenotype from that website now live, and I have now these clinical codes in R, so I could integrate this whole thing into, whatever analysis that I'm doing. And so that would enable things like being able to, alter your analysis to try out different definitions and see the impact it has very easily without kind of having to write a bunch of new code. And as well, we have a model for making this accessible inside TRE Bank. Those are locked down environments without internet access, but we have a model that enables you to access this there as well, so that actually you can apply this to the data such as sale data and have a whole kind of end-to-end workflow. We also have authorship where you can go in and create new definitions. You can search for codes and do things like that. So the relevance, I think it's already a resource that we believe would be useful for clinical trials if you're working with routine data. It's already available there for anyone to use who's interested. We have a collection of definitions that have been developed for various projects that may be useful, but also it's available as a resource where you can contribute your own content. If you have definitions that you're creating and would like a place to be able to share them, publish them, make them more visible, then kind of having it be in the supplementary data of a paper or something like that. And also it can be a way to kind of increase visibility of your work because it references your publications and things like that. But besides what it can do now, we're really interested in discussions about how this can further be developed to support specific needs of trialists. As part of our current phase of work in HDR-UK, we're engaging with a lot of different groups to kind of assess how useful it is. Is it now, or what new features should we be adding? What things should we be working on to make it support what you're doing? So we'd love to, if anyone's interested but has ideas of things that it really ought to do or things that would be really useful for you, we'd love for you to get in touch and we can talk to you and find out more. So thanks a lot. And our team is highlighted on the website there, and also on the website there's a contact place to get in touch and request an account if you'd like to use it, or get in touch if you'd just like to kind of have a discussion about how it may be useful to you. Thanks a lot.
That's great. Thank you very much, Dan, for that focus on the phenotype library and that really great work that you've been undertaking. We've got just under 10 minutes for questions. So if people have questions for any of the presenters, or just a question for anybody online, please either put that into the chat or raise your hand, and I'll look out for hands as they come up. I can perhaps start off. I mean, Dan, you asked that question at the end of your presentation about, or encouraging people to come and talk to you about what you could do to better support this activity in clinical trials. And some of the work that we're doing, I guess, in Cardiff and with Marion's team is about engaging with trialists about what they need and what they want. Is there anything that trialists could be doing that may be the other way around, which might be particularly helpful for you? So let's think about this as an interaction. What would you like from trialists? And that might be taking up some of the opportunities that you already make available. But is there anything that you would particularly want from the trials community that might be helpful? Sinead, Sinead, Simon, or Dan?
I think in terms of the phenotype library, if people do generate new phenotypes, to upload them, really, because it is sharing that stops other people having to do this. So thing with children, and so how diseases are defined in children is often very different than with adults. And when we started looking, there wasn't very much out there, so we had to go and do it from scratch. And it would be very, very helpful when people do it if they are uploaded and share it. And so we will be sharing how do you define these conditions in children, which we developed with pediatricians. But I think literally, if you develop something and you think what you've done is useful, share it with other people so they can benefit from that.
That makes complete sense. Dan and Simon, anything else to add on that?
I guess we'd like to hear about the problem, really. I guess part of my job here is to solve problems, but everything we built is because someone's come with a problem and they need a solution, and we could do it. So absolutely everything in the entire world is solvable, but actually we could work together to kind of find a solution. I'm an accidental expert on information governance because it's like everything we do really is within a legal framework. So even the proposal for DigiTrials, that was an idea from Welsh Government. A couple of days we put a proposal in. We think it's a legal, sound way of doing it. I think everything is achievable, and I really would like Wales to be much more active in pushing the boundaries about what is possible. That's what I'd like.
Yeah, I agree with both Sinead and Simon. I'm interested in both of those points. As well, I think clinical trials may offer really interesting opportunities for validation of kind of the routine data, because a lot of the challenges are around lacking a gold standard and not knowing if this definition is correct and finding the right people. And trials, by the way they're set up, may sometimes be able to help with that, because they may be selecting people based on kind of clinician reviewed criteria, or they might just have multiple sources of the same information if they're using patient questionnaires and routine data. So it might be interesting to explore if there's any kind of collaborative opportunities where that could be used to then actually go and validate phenotypes in the routine data and see how well they're doing against these other sources.
Yeah, I agree, and I think that one of the work packages in the Transforming Data for Trials workstream will be looking very much at that. When you do a sort of straight comparison of bespoke data collection within a trial, how does that match up to the routine data that might be similarly available? What are the strengths and weaknesses, and I think there's a lot of interest really in getting to a point where you can be confidently relying on the use of routine data rather than having to go back and collect these data from patients. I can't see any questions at the moment in the group. I mean, I think, Simon, one of the things that you said, which really struck a chord with me, was that essentially you take care of the infrastructure for the holding and making the data available, and that means that trialists can concentrate on just running their studies. And I think, to me, that is one of the major benefits, is actually you don't have to do absolutely everything. You know that you can compartmentalize it and say, well, actually that's Sale or whichever TRE you're working with who can do that. And I guess there's some learning that needs to be developed about at what point you can sort of hand over those responsibilities, and what that still might mean for a trials team. I think that's been the focus of some of the training that we've developed to date, but I can see that still being a part of what we need to do more work on.
Yeah, and another aspect of that is that everyone thinks that if you put your data in a TRE, you're giving it away, right? And we have a lot of problem with cohorts in this sense. Cohorts, people who run cohorts are in love with their cohort, So it's like you can share your cohort data, and we can still make the legal owner, and you can stay the data owner, and every time someone wants to use it, you can be asked for permission. This is not a problem. It is about enabling sharing under whatever the rules of engagement that is necessary to make it happen.
Yeah, and I think that
chat. I think there's 2 questions in the chat.
Okay.
So when searching for specific data, how does one find the correct platform? So how does somebody find the data? There's HDR-UK Gateway, where you can go on, and if you're looking for specific data, you can put in there, and then you can find where it is in the UK, for example. So everything that's on sale is on the HDR-UK Gateway. So you can see what data's in there, what the different columns are called, really. So the type of data in there, and then how you go and ask for it as well. So there's
there's a second component of that question from Gerda about pseudonymized data. Has data been pseudonymized according to information governance? I think that answer is probably yes.
Well, the answer is yes for Sale, but it's also the answer because we're joining 39 TREs. There's a difference model, and most TREs will pseudo-anonymize because it is the safest way to operate. So for Sale, DPUK, and for LLC, the big ones, they are doing this. We do have a couple of tenancies where they do not, and it's fully identifiable, and that's fine because the rules, if you like, that they operate under are different. So it's not mandated, but I think it is safer to do this. But the thing about pseudo-anonymization is actually doesn't mean you can't then go back to identity. It just means there is a whole process and a whole lot of hoops you have to jump through if you needed to do this. So for clinical trials, a few times now, the tracking of adverse reactions and so on and so forth, there is always established process to seek identity to go back to their feeding in death into it, so that again you can drop people from your trial if should they unfortunately pass away. These are sort of well-established pipelines.
Okay, thank you, Simon. Any further questions? In which case, I just want to thank all of our presenters today. I think it's been a great opportunity to learn about what is being done really well and is effectively world-leading from Wales. I think the opportunities that now arise with the new funding for HDR-UK is extremely exciting, and I think we will bear the most fruit if we keep on talking to each other about the problems that we have, Simon, and the solutions that could be put in place to solve them at both ends, if you like, of the spectrum, those who look after the data and those who are in the field conducting trials, and every point in between. So thank you, everybody, and thank you for your time today. And remember that the recording will be available at the end of this meeting for those of you who want to recap and be in touch with any four of us, please do that as well. Okay, thank you very much, everybody.